gentleman from Georgia, Mr. Carter.
Thank you very much, Madam Chair, and thank you, Dr. Matthews, for being here, and thank you for the work that you do and leading MedPAC and helping and doing your best to keep prices down as well as providing the best services that we can to the recipients of Medicare. It's extremely important. Earlier this month, in this committee, and in a bipartisan fashion, I was able to pass legislation that I sponsored, bipartisan legislation, along with Representative Giaforte, Representative O'Harian, Representative Welch, called the Payment Commission Data Act.
Yes, sir.
Which is going to allow MedPAC, as you know, to be able to get data relating to prescription drug pricing, and you in turn will be able to use that data to make recommendations to us here in Congress. Can you just comment on that firsthand, on how that may be able to help you?
Yes, sir. And before I do, I would want to express on behalf of the Commission my appreciation to you and the other co-sponsors of this legislation. One of the ways that the Commission has been hamstrung in terms of being able to evaluate the effects of the various rebate structures on the Medicare program and its beneficiaries is we do not have access to that level of granular data with respect to rebates on a prescription by prescription or drug by drug basis. And so, for example, when we commented on the Office of Inspector General's recent proposal to eliminate rebates in the Medicare program, we were only able to evaluate that proposal through its aggregate impacts on the program, on beneficiaries and manufacturers. We simply did not have the level of detail in order to be able to assess it would affect this group of beneficiaries who are taking this class of medications for this variety of conditions. And so having this more granular data on rebates would help us do those kind of analyses and help inform the kinds of deliberations that the committee is having on a regular basis.
Right, and I certainly think both of us would be remiss if we did not mention that information is only going to go to you. You're the only ones who are going to see it. It's not, we get it, it's proprietary information, but it's not going to be released to the public. It'll only go to the Commission.
That is correct, sir. MedPAC has a sterling track record in terms of handling proprietary and sensitive data.
I want to ask you about DIR fees. You're familiar with DIR fees, and you're familiar with what the administration, what Health and Human Services, CMS specifically, has proposed in changing the rules so that DIR fees our discounts will go directly at the point of sale, as you mentioned earlier. But there were two things that you mentioned in your letter to the administration or to HHS about DIR fees. First of all, that DIR fees had grown from $229 million in 2013 to $4 billion in 2017. $229 million to $4 billion. And of course, for those of the people who don't know, DIR fees are essentially clawback fees that go to the PBMs placed on the pharmacies. You also mentioned that the amount of the DIR fees that the plan sponsors were recouping actually exceeded what they had proposed and what they had really had projected. Can you comment on or explain what that disparity might mean for cost sharing?
So yes, what the short answer is that this means beneficiaries at the point of sale are paying a much greater amount in cost sharing than they should be relative to the effective transaction price between the manufacturer and the plan.
Exactly. Exactly, and I know that MedPAC has put out some different solutions to the DIR fees, but the point is that you agree that DIR fees are a problem.
Yes, sir, that's correct.
Okay, good. Very quickly, in what little time I have left, of course, one of the things that we've been talking about on this committee and in Energy and Commerce and specifically on the O&I committee has been insulin pricing. And I just wanted you to comment very quickly that I understand there's a lot of variability in the different plans on how they cover insulin, but can you explain how does the Medicare plans cover insulin, particularly for those patients who are in the donut hole?
If I could get you to ask the question just slightly differently.
Well, in other words, I know the different Medicare Part D plans cover it in different ways, but making it affordable, making it accessible is something we're very concerned with, particularly on this committee. How can we do that? How can those plans do that in a better way?
Again, our recommendation to restructure the Part D benefit would mitigate the incentives for plans to use these high-cost, high-rebate drugs, and insulin is one example of those kinds of things. And by better aligning the plan's incentives, it would potentially reduce the influence of DIR on the cost that the beneficiary faces.
Right. Again, I want to thank you for your work, transparency and accountability within the system, particularly with the third party, the pharmacy benefit managers, the middleman. That's what's going to help us. And there, transparency is the best disinfectant out there, and sunlight is, and that's why we need it so bad. So thank you for your work on this, and I yield back.
The gentleman yields back. I now would like to